This is going to be, the post-lunch talk that you guys can get up and walk around. If anyone's falling asleep, I tend to drone on, so feel free to get up and move, because I know what it's like to be falling asleep in the middle of all this. I'd like to thank the organizers for the invitation. It's always a really stimulating meeting. I come out of here with so many ideas to go back to my patients and try to apply them. Today I'm going to go over laser ablation. How do I advance? This? Okay. Disclosure-wise, I have a relationship with the two companies that make the lasers, but there's no finances, so I am being an advisor to them. So in summary, MR-guided laser interstitial therapy is a very long word. We call it stereotactic laser ablation. It really is minimally invasive neurosurgery. It creates a 2-centimeter ellipsoid lesion that is the product of laser light being bounced off a lattice of mirrors at the end of a fiber optic catheter that we put inside a cooling cannula. And it combines MR thermography, which I think is the big advance here, but it's also the laser itself is an advance, and it's feedback controlled. We can control it both automatic and a manual shutoff. And in Europe, there is a CE mark that is pending, and they tell me it's within a year. So it's a very small incision, 4 millimeters. It's a 3.2 millimeter burr hole, but the most important number to remember is there's a 1.65 millimeter corridor down to your target. And you've seen some of the open operations that we've talked about. The corridors are a lot bigger. You can confirm your targeting before you turn the laser on, as opposed to old school stereotaxy, where we used to have to rely on our numbers before we turn the radio frequency generator on, and be happy with that. Now we can see we're in the target before we do anything. It's feedback controlled, as we mentioned, and I've come to rely on these automatic cutoffs, because one advantage of one particular system called the Visual Ace is you can put a cursor on a structure that you don't want to injure, and if it gets anywhere close to a 48-degree number, the computer will cut the laser off. And I rely on that more than I rely on the manual now. And because it's thermal, it's an immediate effect. Because it's a minimally invasive approach, is minimal hospital stay. So I'm asked to talk about laser ablation a lot, since I do it a lot. And one concept that I try to bring to the general neurosurgical world is we're always trying to define what the ideal patient is. Hypothalamic hamartoma fits all those criteria. It's focal, it's deep, it's a lesional disorder. It makes a lot of sense. So in the grand scheme of epilepsy surgery, it will have a fit on these particularly tricky targets. But the origin of the idea really came from Angus Wilfong and I at Texas Children's. And although we have a large respect for the evolution of hypothalamic hamartoma surgery over the years, where for years there was nothing and then there was these advances, we are also struck by the morbidity that is incurred. Now, compared to nothing, there were great advances, but we always thought the morbidity was pretty high, especially when it came to memory and hypothalamic obesity. So other more astute speakers have gone over these details, but it's just a reminder of where we were coming from. We were looking for a minimally invasive approach to be effective, but really safe. So we're trying to convert these big operations into something that leaves the head intact, leaves the scalp intact, gets to the target with a minimal approach, and is effective in the lesion as opposed to incurring a lot of deficit, what I call corridor-related complications as the surgeon tries to get to the target. The real advance here is the fact that we can see it happen. MR thermography is a way of setting the MR, the usual MR that everyone uses, to look for a chemical shift in the proton resonance frequency. And what that reflects is a change of heat, not necessarily primary heat, but a change in heat. So this is the thermogram here, this blue field here, so the brain is isothermic when it comes to that threshold. When you turn on the laser, you see the heat inducing here. Now we take this image, we fuse it to an anatomic image, so we don't look at this blur and think we can see something. We're fusing it actively to an anatomic T2, a very precise T2, and I see what I'm doing. But the most important thing is about this technique is we can watch it happen in near real time. The refresh rate depends on how many planes you're looking at. Refresh rate for each is about 3.5 seconds. So the idea behind thermal ablation is like in RF, you heat up the brain until it either stops making seizures or the cells themselves die. Below 43 degrees, not much happens. Between 44 and 59, it's time dependent. And this is put into an Arrhenius equation where we know that each pixel at a certain temperature over a certain time is going to result in cell death. That changes color, at least on the visual aid system, where you can see that color change superimposed on your MRI, and you wait until your color change covers your target. At 60 degrees, it instantly coagulates, and at 100 degrees, it's gas, so we don't want to do that. And there are these zones. They're ill-defined at best, and a lot of this stuff was done in models that weren't looking at excitable tissue as often. But there is a coagulation zone, which you can clearly see. And then there's a zone around it, which is apoptotic, meaning it's been triggered to conduct programmed cell death in a delayed fashion, much in the way of radiosurgery. But then I think there's a third zone that would explain how we can get better efficacy with minimal damage, in that there must be an effect of heat on an excitable tissue, some level of thermal injury that stops a brain cell from propagating action potentials, but yet the cells are alive. So it's an interesting thing to look for. Next billionaire I find, I'm going to ask for a funding in that regard. And then the disconnections. We need to keep in mind we can be disconnective as much as we can be ablative. White matter is more sensitive to heat than the gray due to the blood flow. So it's destroying the epileptic tissue, but also it is probably disconnecting to some degree. And my strategy has always been founded by two notions. One, we think hypothalamic hamartomas propagate into the brain through the mammillary body. We think. We don't know. No one's really proven it, but there's lots of secondary evidence that that's the case. So that's where I target. I try to get the tissue just above the mammillary body. The other thing I try to be sure of I do is that some of the French literature looked at PET scanning and realized that the more metabolic portion of this hamartoma was at the connection between the hypothalamus wall and the lesion itself. So I try to take my trajectory through there as well. So in one trajectory, I get to the mammillary body connection and I get to the hypothalamic connection. So if I can't get the whole thing, I at least got the connection points. That would explain why this is our first patient. I didn't do a very good job when it comes to anatomically destroying his lesion. I just got the back part, but he's still seizure-free after 6 years now. 5 years. So I'm going to go into some of the details on the planning of the operation. Perhaps it's a little bit too into the weeds, but it'll give you some idea of what we have to go through to get these things done. We do stereotactic planning. All the imaging that they come to us with is just diagnostic. It's just for the radiologist to tell us what's there or not. I need to redefine the lesion in 3 dimensions, so I have to redo all the imaging. So then we stereotactically place the fiber within the target, and then we do the ablation. So the planning is very much up to the surgeon. I like this BrainLab iPlan software because they bring in all the modalities, but other people are wedded to other softwares. The surgeon's comfort is most important, because what you want to do is take into as many data sets as you can to be able to include them in your plan, because you're looking at disconnection and the actual metabolism. And then you want to create an avascular approach. You want to have an area, a 3 millimeter corridor in which there's no blood vessels that you're going to be able to get to the mass. And we use multimodal imaging. Here's an example of us using the PET to try to find where the most metabolic portion of this lesion is, with a little inset window here. I do tractography. I did an example of a larger one, because when I do the mammillary bodies and the fornices, they're kind of tough to see sometimes. I can look at some of the contrasts in some of the other modalities, such as flare. Sometimes you can see the border with flare better than you can see it with the others. And then here's this avascular trajectory that we pick. And I have a 3 millimeter error zone, so I don't get into any blood vessel. So then we put the catheter in. You can put this in any way you want. I rely on rigid stereotaxy for the most of the time. I think that's the most reliable, because a long trajectory like that in a small target, you have to be pretty precise, but there's lots of ways of doing it, as I listed here. What we've gone to lately is something entirely in the operating room, entirely in the MRI. The ClearPoint system, which is designed for image-guided DBS. I do a laser with this as well. And also, if I have to do multiple trajectories, I use a robot. So of a French company. I really rely on this. It really saves a lot of time, and it's very accurate if it's bone fiducial guided. And then you can perform this ablation either in the MR suite, because you have to transport the patient over, or you can do it all in the suite with the ClearPoint system, or you can do your own intraoperative MRI, which we don't have yet, but I'm hopefully going to have one soon. So the two systems that I need to mention, Visualize by Medtronic and NeuroBlade by Monteris, they're similar, but there's major differences as well. I have vast experience in this, minimal experience in this. So the big contrast is one is saline cooled, one is gas cooled. It has its advantages, and you can do a cryo ablation as well. But the cannula in the Visualize system is a lot smaller compared to the NeuroBlade, so that's why I don't use this very often in hypothalamic hamartoma. In fact, I think there's only been one case that I know of, and it was in Vanderbilt that did it. The wavelengths do matter. You have a quicker uptake of heat here. This is a slower system. I have two diffusers on this. I can make a more precise lesion with a Visualize than I can here, but this is a side fire system. I can direct the laser. You can't direct heat, but you can direct a laser, and after about a minute, your conduction of heat catches up to you. But if you really have to do a precise thing, you have to go in one direction or another. Having a directable laser is a good advantage, and I wish they would get one that's this small. And then you have to do some manual feedback here. The console, you can see a little bit better with this system, and this has, and the NeuroBlade has a robot to advance your laser, which is a little bit of an advantage. What we actually see during the operation in the old days was kind of a blurry scan. It didn't look very well, or look very clear. Now what we see is this crisp T2 in a split screen. So here's the anatomic scan, and here is a thermogram. I can watch the heat change here, and I can go back and forth with this split screen and see exactly where my lesion is accumulating, okay? So that's what lets us be very, very precise, and I can put a marker here to be sure that this lesion, or that this area here, if it gets too hot, it'll cut off. This is a view of Monteris. It allows some advantage in that it's 3 dimensions, and it's directional to some degree, but that safety feature that I really rely on in hypothalamic hamartoma is not present here. So you have to watch all 5 planes at once to be sure you don't get too close to your structures. I find that too challenging. And then we do a test dose. Here's a few test doses to see. Now this is superimposed on another anatomic scan to see if it's where I want to be. And then I turn up the laser, and I watch what is called the irreversible damage map cover my target. And I confirm it. I get a diffusion scan, and I confirm it with my window in real-time fusion. And I can see where the thermal injury is going over my lesion and not into the hypothalamus. I can confirm it with a volumetric scan. Now a non-enhancing lesion becomes enhancing. That's causing of the thermal injury. And I can do it volumetrically on the fly too, and be sure that my structures, my fornix, my mammillothalamic tract, my mammillary body were not involved in the lesion. Take it out, we throw 1 stitch. So it's neurosurgery that doesn't look like it. So the money slide. How well are we doing with this? It's been about 62 ablations now. With 49 patients. A number of them have had to do redos due to a philosophy thing that I'll mention. About 83% are free of the gelastic seizures. Now, I count seizure freedom. I'm counting the gelastics. Obviously, that's a simplification of the condition, but that's the target that I'm going after. We have a series of patients that are over a year follow-up, and it's maintained to a great degree. 2 kids have gelastic auras. I don't know what to make of those. They're not disabling at this point, but they could be in the future. A lot of these kids had secondary seizures, but they're now easily controlled with medicines as opposed to before where they were breaking through because they were being driven by an active HH. Of the series, 5 had previous cranies, 3 had previous radiosurgery, and 7 needed more than 1, 2 needed 3. And I'll go over some of those cases. We presented this at AES last year at 78% on the more than 1 year, and it's the similar outcomes that we measured. So far, it has maintained, but we will see. So looking back on our failures, we've had targeting failures where we can be a little off with our stereotaxies sometimes. We can have dosing failures, especially in the early days where I really didn't know how far to go, so I would underdose and I'd leave some behind. We've gotten a little braver over the years. And then there's some weird things that can happen. These laser diffusers are pretty sensitive, so they can be fractured. And here's a brainstem hit that we had asymptomatic, but we got lucky. We've learned a lot on how to handle these devices. Our biggest disaster, as Dr. Regie has mentioned, has been published by the NYU group who referred me the patient, but it was in my hands that this happened, was a kid who had a temporal lobectomy. So already his right side memory systems were not working. And we did a stereotactic laser ablation of the hypothalamic hamartoma they found when his brain relaxed a little bit after his temporal lobectomy, and they didn't know that he had. Well, I went by, as I usually do, all of the other safety features, but I was going by the premise that this thing has a 1 millimeter cutoff, and I was wrong. We put a safety marker in front of or on that mammillary body, and it went beyond, and it did injure the mammillary body. I knew this by him asking the same questions immediately the day after. So he is basically got a Korsakoff syndrome. He has very little short-term memory, and he gets very anxious when this occurs, and he is not functional. And he's walking and talking, but he's not a functional member of society and needs 24/7 help. And the family had the means to do it, but this was an unmitigated disaster that we stopped our program to see just what happened. We went back in the data of the preliminary studies, and we realized that this 1 millimeter cutoff is really kind of an average. And it's been confirmed in the clinical data too. So we regrettably learned the hard way about respecting these new technologies and learning the limitations of these new technologies. It hasn't happened since. My principal is having more than a millimeter, usually 2, between the heat source and my safety marker, and this hasn't happened again. Perhaps it'll lead to some under-treatments. We'll find out. And going back in the memory, we had some subjective complaints of memory, and especially in the teenagers, but when we tested them, their memories were either stable or they were improved. Other things that have happened, we had one case of DI on a kid where the hamartoma was very, very close to the stalk and the swelling stretched it, and she has DI now. I had one transient sodium fluctuation patient that was reminiscent of the old, back when I used to do the open procedures where they'd have that cycling of hypernatremia, hypo. This child only had one cycle, and then it resolved, so it was relatively minor. I don't have any cases of hypothalamic obesity that I can attest to were ablation related. Now, and there's a few reasons why that gets a little confusing and a little qualified, and I'll mention that in a minute. And behavior, so endocrine is the same scenario. We haven't had any induced endocrinopathies, but I have not studied it to the extent that the Marseille group has in their series. And if you look at the behavioral improvement, it's very poorly studied. It's a interview in the clinic notes, but about 30 to 50% say they're improved, but it's not necessarily related to those that were cured. We use a lot of postoperative steroids because it's an instant thermal lesion, and I think that's important to know for a number of factors. One, it keeps you out of trouble. When you have a lot of swelling in your hypothalamus, you become very, very symptomatic very rapidly, and it's a very difficult thing to handle. The high-dose steroids have eliminated that notion, but they're very high dose. I get that dose from the old school glioblastoma days where people would come into the emergency room with 1.5 centimeters of midline shift, and we'd tuck them in with 10 to 20 milligrams of Decadron Q6 for almost a week before we'd go back and take it out after the swelling. That's where I get this concept. But that also has a major endocrine hit, and it has behavioral problems. I mean, you get them cranked up on that much steroid, especially a kid with a history of rage attacks, and you're going to have trouble. So that has, I think, one of the reasons why we do get some of these complaints, but they usually resolve by the time all the dust settles and all the steroid is out of their system, which takes about a month or so, maybe even longer. So other little complications, a few missed targets, 2 of which had to be abandoned. We had a weird reaction to phospheny when a kid was NPO all day and we just IV dosed him. This transient memory dysfunction, hyperthermia, hyperphagia was the only kid we didn't use steroids on due to an intolerance. So we learned our lesson. We had one little hemorrhage from pushing the dura too much. I've learned from Jorge Gonzalez in Cleveland, does a lot of stereo EEG to burn through all the dura, and that's an easy thing to fix. Haven't had a problem since. We had that one injury to the diffuser, and that's a little hit that this kid had, but asymptomatic. And we've had a few scalp injuries burning through the dura, which have been minor. One of the things we found out about doing thermal imaging and thermal therapies is that we know almost nothing about the dynamics of the brain. There are temperature fluctuations that are involving the brain. Even though the thermogram looks like a nice blue field because it's set at a certain sensitivity, underneath it are some pretty variable temperatures. And there's some heat sinks that the cisterns will suck away heat and the ventricle will suck away heat. Here's an example of a 1 to 2 millimeter change between, here's a kid with a type 3 pushed into the cistern with very pulsatile, high pulse pressure CSF around it. I couldn't get anything done at a normal dosing. It's like a standard dosing. And then I move it a little bit and I can finally make a lesion. So every millimeter matters. And we have found this out over time. And that heat sink can really complicate approaches in the larger ones as well. Here's an example of a giant HH that we went after. And after a number of ablations, the ventricle kept this bridge cool and was likely symptomatic. Now, this is a family that really wanted a third ablation. I said, I really want to go after this in another means, maybe an endoscope, maybe some other way. They didn't like it. They went to Japan, and I don't know what happened. But that's the sort of problems we run into with these heat sinks and why we have to take it very seriously, because these coolants around the lesion can cause the incomplete treatment. Here's another evolution of this, of another hamartoma that we had. We approached this with a large series of ablations, and once again, the ventricular surface cooled it off. And I'll go back to this kid because it was a diagnostic challenge as well. So we are applying heat where we don't know where it's going to go. So we're thermal therapy without thermal planning. We're anatomic planning, but not thermal planning. So the microthermodynamics need to be addressed. And we could also use a small steerable laser to get around some of these heat sinks that we encounter. Here is the thermogram, and that white dot means that that's a very high density thermogram, heat sink. So the information is there in the MRI, and we've had a few ideas using Verina's concepts of where she finds the resting state conductivity below the signal and below the noise in functional MRI. Perhaps there's a pattern in the thermogram that we can pull out as well below the noise, and we're working on that. What I want is I want a topographic map, just like this oceanographer's map that shows you where the depths of the ocean is. If I was going to ablate Norway, well, I wouldn't start out here. I would start closer to where I'm going to sink off, okay? That's what I'm hopefully going to get pretty soon. Here's a case study a lot of folks are going to show you their good examples. I'm going to show you my bad ones. Here's a case study in which we were trying to figure out where in this lesion to ablate. And it's a very large lesion on a child from Russia, I believe. And it taught us that these things are heterogeneous to a great degree. We did a few ablations in planning of destruction and disconnection over time. Here's a large ablation occurring in the middle of the hamartoma. And we're trying to go for this connection here with our safety markers on the optic tract you can see here, and a safety marker on the fornix. And there's the result, the post-scan. But he's still seized. He was still having seizures. Not as bad as they used to be, but he was still having persistent seizures. And I looked at his post-operative MRI, and I'm wondering how this shell is causing any trouble at all. So I had Verina go through her resting state system, and we did find some areas that were pretty active, that this area was really connected to a lot of this child's brain, and it wasn't just too near the fornix. We looked at it. So we targeted, okay, I'm going to have to go after that little area, and that's what we did. And so far, so good. But that just goes to show you how sometimes the heterogeneity of these things and the heat sinks can really conspire to make this a very complicated approach. So summarizing some of these ideas in the context of the rating scales of the lesions. In the Delalan manner, we almost never need to go after type 1, so I didn't really include it. It's ideal for type 2s. It's not so bad for type 3s because I can span the area and I can disconnect by the MRI. And type 4 is a challenge, as I pointed out in a few cases. From the regime method, or the regime classification system, which is more stereotactically based, type 1, 2, and 3 are pretty good targets for the laser. Type 4 is very challenging. Actually, I'm sorry, it was type 5 is your is the Delon type 1. Type 4 is particularly challenging mainly because we see that the fornix runs either through or on the inside of the hamartoma in these cases, and it becomes very treacherous to put heat there because it's no longer cooled off by the cistern below it. So we have found these type 4s to be particularly challenging. We have about 3 of them now, and they're doing well, but I'm very nervous. And of course, type 4s are giants, and no one's got a very good solution to that. So advantages. It's a minimal corridor, obviously. It's a short hospital stay because there's very little pain. Instant effect, but not necessarily the network. I can see the plane of this hamartoma as it goes against the hypothalamus on the MRI better than I can with my own eyes under the light microscope. So that's why I like this as opposed to an endoscope, which is light, and a microscope, which is light. There's a low complication rate so far, although when we have them, they are doozies. It's ideal for reoperation because you're not having to go through scar. It's ideal for the high IQ kid because I think I can protect the memory better because I'm not having to move the fornices. And it's best for the first 3 types. And here's an example of reoperation. Here's a big scar kid, large operation, didn't get it all. I could pick a different course through the brain, 1.6 millimeters, and ablate this, and he's cured. And it was very easily done. No more morbid, in fact, far less morbid than a redo operation. I've redone my own failures, and I have redone radiosurgical failures, all that they seem the same. Disadvantages, well, lesion size is a big deal. I'll show you an example of that. It's non-steerable. You need multiple cannulas sometimes. The technology is evolving, and our practice is evolving with it. I'm getting more and more aggressive, so you're going to see some early failures. There's these heat sinks we talked about, and it's really challenging on the type 4. So here's where size truly matters. Here's a type 4, I think. Maybe type 3, but type 4 I would call this. Very broad-based and is more than 2 centimeters. And as many heat sinks, it's surrounded by heat sinks. Now, our philosophy between Angus Wolfram and myself was to do one good ablation and see how far we get. Try not to be aggressive up front. Try not to take risks up front. You know, we don't know what it's going to do. Maybe just do one good ablation. Well, I think that has led to some failures, and this kid was a failure because clearly we were undersized. Here's another kid, you know, kind of a young kid, lots of seizures, clearly headed for epileptic encephalopathy, but so young that the myelination, the immaturity of the brain, it makes it very challenging for me to find where the hamartoma stops and the hypothalamus begins, but with some inverted recovery sequences, we were able to find some borders. And we did multiple catheters on this child, but again, cooled and under ablated. So we went back and did another one up the top. And I got more of the lesion, but we'll find out whether that did the job or not. So some thoughts on how we approach this and where SLA fits into HH. When it first came out, Dr. Ricketts sat me down, came to Houston, and sat me down. I'll never forget him saying, "Don't let it be the only arrow in your quiver." And that makes sense, but I can't help but see ablation alternatives everywhere I look now. So that's why I like to come to these places and hear other approaches. There's a staged surgery conundrum here. I would love to have everyone move to Houston for 6 months and let me go at it very slowly, but that doesn't work out that well because there's always these urgencies that we're pushed at. Maybe they're epileptic encephalopathy or losing function. There's the morbidity that we would incur by being radiologically complete, but perhaps unnecessarily complete in the context of the clinical scenario. There's cost. You know, these things are expensive. Redoing them is expensive. And there's traveling. You know, people are coming from all over. It's a rare disease. So all those things really lead to a conundrum of us trying to be conservative and do one ablation at a time and see what we get to let's be definitive, because if we don't satisfy the family, they'll go someplace else and get something maybe they shouldn't have gotten. And I have to quote Dr. Raji in this concept, who's put words to the idea that we've had, a lot of us have had, is try to do combination therapies, because maybe not one is going to fit every clinical scenario and every lesion characteristic. And we got to really complete our lesion-specific outcomes. We got to figure out how the software can get a little bit more compatible. We have to figure out this thermal threshold. Maybe we're overdosing. We have to figure out the thermodynamics, and we have to see a little bit better. Dr. Raji already mentioned this is the Gartner curve applied to, technologies. But here, where are we? I think a lot of people are here. I'm here. I'm past this, and I'm trying to figure out where the slope of enlightenment is going to take us in this technology. And with that, I will end.
Thank you very much. Any questions for Dan? No.
Yes.
Can you clarify from your outcome, can you clarify if you count both gelastic seizures and the other types of seizures, how many of them were seizure-free or Engel 1 and 2 then?
I'd have to look at the actual numbers. Okay. I'd have a feeling there's a number of them that had kind of a increase in their non-gelastic seizures after the ablation, which is a phenomenon I don't terribly understand, but it does happen. So that would complicate matters. But after a year, that of course settles out. I'd have a feeling it would drop it by 10%. That would be my guess off the top of my head. I'd have to look at the data though.
Am I allowed a quick? Okay, thanks a lot. So it's actually it's a combined question for you and Dr. Varina. Sorry for calling you the first name. It's very difficult for me to pronounce the second. I'm allowed to say that because I also have a very difficult surname. I just wanted to ask you, I think it's a very interesting approach what you do with the resting state fMRI. I mean, if I have understood the technique well, you are inferring connectivity from actually temporal correlation of oxygenation practically, if I'm correct.
Yeah, I'm going to stand up here and act like
when
I
they
know
light
it,
up at the same time, you're inferring connectivity. You're
but
inferring
she's right back there. Generally that's the basic understanding of what I have is these are bold signals that are oscillating at the same frequency. Is that fair?
Yeah.
Right.
So I just wanted to ask you, have you come across cases where you operated and then you had the failure, but then you could not find any seeds on the hamartoma that was left or on the lesion, but you still had seizures, probably proving that there was a Kindle effect and there was an epileptogenic network that survived even after you killed the hamartoma?
That's a great question. We have seen connectivity changes occur beyond the hamartoma from successes. That has happened. Verena can give you the number of how many people. I've seen a few come across my desk and say, oh, that's kind of cool. The reverse I know is true. There was one child, one of the problems in redoing this, and this is why I asked Dr. Raji how his redo rate is. When you redo a laser ablation, when you're doing a laser ablation after an open surgery, it actually makes it more difficult because if you dig a hole in the middle of the hamartoma, that's a heat sink. So a lot of times I have to pick right or left if I'm going to do one cannula. Lately I've been doing two, but I have to pick right or left. And I picked wrong on one kid. And Verena's post ablation resting state, this is when we first began to do it, showed that the other side was way more connected. And I ablated that and he was seizure-free. So I know there are some scenarios in which it works. And I can, perhaps on an N of 4 or 5 conclude there's a connection. But the proper study for that, seeing how many of those resting state conductivity studies really led to improved surgical strategy and outcomes, is pretty labor intensive, and we're in the midst of doing that. It takes a lot of analysis, as Verena will attest. Off the top of my head, I think there's about 14 or 15 patients that at least we have the data for, and many in my head that were successful, but the numbers I think we need to clarify. We're working on it.
Okay, one more question.
I hope you don't think this is a rude question, but you said it was costly. How much does it cost?
Oh, it's not rude to ask how much it costs. The actual numbers, I'm a little bit disconnected from all that. I see the things come across my desk, but then I forget about them. But I think it's about 2/3 of a cranie. So it's not that cheap. And each of these cannula are about $15,000 a piece, I believe. Now they have, Medtronic has a deal at about 2.5, they're all free. Beyond 2.5 cannula, they're all free. 2.4 or something as the numbers come out. But they're not cheap. And this is not a cheap technology at all. Plus you have to take into account radiology time, which is pretty expensive, OR time, so now you're doubling your time. Maybe our intraoperative MRI will escape some of that cost. The way we save it is in the hospitalization. There's no ICU charge. These kids are sitting in the regular ward for 24 hours, and they're gone. So I save the insurance company's money on my minimal stay, but I make up for it on the cost of the new technologies and the. So it's a little cheaper than a Craney, but not that much.
I suppose what I was asking really was if a family from the UK came over, how much would they be charged as a total amount?
I'd have to look at the actual number,
We've
but I
looked
think.
at it 'cause, we've been doing those.
Do you remember the number?
I can't remember. Can you remember?
I think it was about 120,000.
120,000. Yeah, by the time we
120?
With a pre and post.
Yeah.
MRI.
Yeah.
It's just insane.
And when we've been looking at it, because it's not here yet, but you know, the issue will be the reimbursement. You know, because we're in a state system, and the whole issue is reimbursement from the virtual reimbursement because we don't see anything. The issue will be the reimbursement of the cannulas and the disposables, if you like, because it's all very well having the equipment, but then it's the the case by case basis.
Yeah.
That might be.
Do you want the microphone here? I should have used
It's
it.
sort of inappropriate, but I just came from Prague from the European Epilepsy Conference, and there were some abstracts about radiofrequency thermocoagulation. You may discuss that yesterday. And I wonder how you kind of, would you think that is an equivalent technique, just using a different form of targeted injury application, or would you say there are clear advantages with application of laser? I suppose it's the MRI, real-time MRI control, which.
I would say they're not equivalent. I think that you can't see what you're doing, for one thing, which always frightens me. One, they're also using, I mean, most RF systems are using it beyond the specs of what the radio frequency generator was created to do for many years, which was to create a small 2 millimeter lesion for movement disorders. There are some higher systems, but it gets very difficult to control that heat at a certain level. So that's, and it astounds me that there's no, we're just learning about all the heat sinking that is going on in the brain. How do you figure that out by just blindly putting a needle in your target and turning it to, 80 degrees for 30 seconds? I mean, how do you know? I mean, in the old days, you didn't have to because you're always in the thalamus, you're always in the putamen, you're always in some place that was relatively isothermic. We're no longer there. So I think it's a clear advantage that you can see what you're doing. You can dose it safely and have safety factors with an MR thermogram coupled laser. Plus the laser is a lot more easily to control than an RF. So that's my advantages.
And you also mentioned to me about because the Japanese have been putting in multiple cannula electrodes, or whatever we call them, electrodes, and doing it that way. And it looks quite, I mean, I thought yesterday it looked quite, it was with several trajectories and really not knowing how much you were doing, it looked a little less.
Philippe Kahn yesterday asked them, why don't you record before?
Yes.
Because you have no.
You've got the electrodes in there, yeah.
Yeah.
They told that they're not doing that.
No, they're doing an anatomic ablation. I think one advance between the old RF days of ablating beyond movement disorders for epilepsy and this is lesion size. Now, not hugely, but the lesion size that was relatively well controlled was smaller with RF, so you had to do multiple tracks. And that's why the Japanese do, on average, 4 up to 8. Sean?
Yes, about the Japanese experience. I think that's a very good team. They are very serious. They are very meticulous. They are doing a number of trajectories in the brain, which is huge, absolutely frightening. I'm a stereotactic guy. I'm a stereotactic guy, so I can say it. Each time we are having a trajectory, we are taking a risk. And I'm very impressed by the fact that with this huge number of trajectories, they don't have, apparently, yet bleeding. But that's certainly due to the fact that they are extremely meticulous and very serious. I think this would be very dangerous to say, oh, this is a good technique, let's do it around the world.
Yeah.
You may have a lot of catastrophe with people
Yeah.
less dedicated
Yes.
and so cautious. And
Yes.
I'm not yet practicing laser ablation, but I think physically that's obvious. This is far superior. And I think this is really the future compared to radiofrequency thermocoagulation. I have one question about how long does it take in terms of MRI suite occupation to perform the procedure?
For a single ablation, and if I'm having a lucky day with all my technologies agreeing and no breakdowns and incompatibilities, I can probably get it done in about 6 to 8 hours.
6 to 8 hours.
Yeah.
So now
I'm getting faster. I used to be
Yeah.
12. So,
okay. So at the beginning we have to say 12.
Yes.
No, that's not a detail in practice.
Yeah, it's lots of calculating and recalculating. It's literally less than 10 minutes of ablating. And the rest of the time I'm planning and putting things in.